Thank you for having me today. So again, my name is Guillaume Pegna. Guillaume translates to William, so I go by Guillaume, William, whichever is easiest. As I said, I wanted to introduce everyone to our NET program here at OHSU. So the first slide is kind of describing a little bit of our core NET providers. Many of these faces that you may recognize. We have Dr. Malak, Dr. Mitra, in nuclear medicine and diagnostic radiology. Dr. Cody is working with interventional radiology, and I'm sure many of you know Dr. Pommier. And I would say that we're kind of the core group. We meet regularly to kind of discuss our neuroendocrine tumor patients, but it would, of course, be silly to say that we're the NET providers at OHSU. And this is only really a partial list of the people who are involved in the care that we provide for neuroendocrine tumor patients. The list is long and it includes support staff, research, multidisciplinary care, because really neuroendocrine tumors are a complex group of diseases and complex patients, and it requires a complex and multidisciplinary approach to the care. So I tried to put as many names as I could on the slide, but really the list goes longer than this in terms of the NET team at OHSU. So addressing clinical trial needs for neuroendocrine tumors. So this illustration is probably something that's not dissimilar to what you all have probably seen before, but it's really all of the systemic treatments that we have for neuroendocrine tumors to a certain extent. So we have a couple chemotherapies, first-line somatostatin analogs, octreotide and lanreotide. Of course, PRRT currently with Lu-Edotreotide, the TKI sunitinib for pancreas neuroendocrine tumors and everolimus. But there are multiple challenges that we are currently planning to address at OHSU. And those challenges include there's really no current guidance towards the integration of systemic as well as local and regional therapies, and I'll talk a little bit more about that. As much as there's been absolutely fantastic progress in the last 10 years, we're still limited in the number and the efficacy of FDA-approved therapies for well-differentiated neuroendocrine tumors. And then lastly, in terms of the guidance after first-line therapies, there's a significant lack of data to guide the timing of second plus line therapy. So looking at the first question, the integration of systemic and local regional therapies, there's no current guidance in terms of integrating systemic therapies as well as local regional therapies. And from a historical perspective, when we talk about the treatment of neuroendocrine tumors, first is always surgery. If you can remove it, that's the goal. And really, after that initial surgery, we consider surgery again if needed. And really, option number 3 is, can we do surgery again? It's always surgery is, can we take it out? Can we debulk? That is always kind of up there on the options. Then once we pass surgery, then we start talking about local regional therapies, ablation, embolization, Y90 radioembolizations. And I would venture to say that even once we have disease that's passed through local regional therapies, we consider doing that again before we go into systemic therapies. I say this is in a little bit of tongue-in-cheek, but historically, that's a little bit what it was, in part because we were just limited in our systemic therapies being not hugely effective and just limited in the numbers. And that's changed recently, specifically in the world of pancreas neuroendocrine tumors and using chemotherapy such as capecitabine and temozolomide. So now we're starting to address, really for the first time, the question of, well, can we and should we move some of these systemic therapies earlier to improve outcomes for patients, help them live better, have them live longer if we give these up front? And this is really the purpose of the SWOG S2104 study, looking at postoperative adjuvant capecitabine and temozolomide. This is a multi-centered national study that we have currently open at OHSU, phase 2 trial, looking at high-risk grade 2 and 3 pancreas neuroendocrine tumors, status post resection, and randomizing patients 2-to-1 to receive 4 cycles of capecitabine and temozolomide versus observation, and looking at the 3-year recurrence-free survival. So this is exciting because this is really the first time that we've looked at adjuvant therapy in the neuroendocrine tumor world from a perspective trial. The next challenge that we're hoping to kind of currently address or address in the future are the limited number and efficacy of therapies for well-differentiated nets. This ties into the RAISE Bio study that will be opening hopefully soon. So looking at the limited number and efficacy of FDA-approved therapies, again, this is kind of the list of FDA-approved therapies for nets as it is currently. First-line octreotide, lanreotide, second-line therapies. All of these have shown really good progression-free survival, which has been the point on which they've been approved by the FDA. What has been lacking thus far is clear evidence of overall survival benefit of these agents. So not only are we limited in number, but also if you look at the efficacy or the ability of these tumors to actually shrink the tumors, then we're even more limited. So octreotide, lanreotide really don't do much better than placebo in terms of shrinking disease or having objective response rates in clinical trials. Everolimus, similarly pretty low. Lu-Edotreotide is on the higher end compared to some of the others, 18%. Sunitinib in pancreas neuroendocrine tumors is probably more in the 10% range or so in the objective response rates observed in the study. So our ability to use systemic therapies to shrink disease is limited. I would say one of the exceptions seems to be capecitabine and temozolomide in pancreas neuroendocrine tumors, where we're looking probably at objective response rates more in the 30 to 40% range. So one of the ways that's being considered as a way of improving the therapies is how can we improve on the therapies that we already have? And so this is a little schematic of Lu-Edotreotide here. So it, as you know, is a somatostatin analog that binds to the somatostatin receptor that's found on many neuroendocrine tumor cells. And the punch that it packs is in this radioisotope lutetium-177. It's beta emitting, which means it releases little electron radiation to affect the tumor locally. And one of the ways that you can consider improving this is just bringing a bigger dog to the fight, specifically looking at the radiation particles. So this is a much bigger radioisotope, Actinium-225, again, conjugated to a dotatate somatostatin analog. Unlike Lu-Edotreotide, which is currently used, this is an alpha emitter. So what that means in kind of more granular detail is instead of releasing little electron particles, this is releasing big atoms of radiation. And one of the benefits is that because they're so big, they don't travel very far. So we think we can give a higher dose of radiation and have that radiation travel less far, so affect more of the tumor and less of the normal tissues. So again, this is not exactly drawn to scale. The actual kind of radiation emission difference is probably on the scale of 1 to 50 to 1 to 80. And so this is really the rationale behind the RYZ101 or RAISE Bio study, looking, and this is a phase 1/3 trial. The phase 1 component is currently open a few sites nationally, and we're hoping to be opening the phase 3 for this trial in Q1, Q2 of 2023 at OHSU. So the phase 1 component is looking at the safety and the tolerability, and then phase 3 will be actually looking at a benefit and progression-free survival, specifically in grade 1 and 2 neuroendocrine tumors that are somatostatin receptor positive and that have progressed after prior Lu-Edotreotide. So this is kind of particularly interesting. After Lu-Edotreotide, what do we do? And so 1-to-1 randomization to RYZ101, which is the actinium dotatate, versus everolimus, sunitinib, or somatostatin analog. The last kind of question that we're looking to address here is there's not much guidance, as I mentioned, in terms of the timing of second plus line regimens. And that's really the goal of the COMPOSE study, which is a multinational study that we have open just recently at OHSU. This is a phase 3 clinical trial looking specifically at those high-risk GEP-NETs, grade 2 and 3, with Ki-67 15 to 55%, somatostatin receptor positive, doing a 1-to-1 randomization of Lu-Edotreotide, so Dotatak, versus investigators' choice of chemo, FOLFOX, or everolimus, with endpoint being progression-free survival. So again, I said soon including OHSU, but as of 2 weeks ago, it is now open here at OHSU. So we're really excited about the trials that we have open and soon to open as well. And just a summary within the the group. So SWOG 2104, looking at newly resected high-risk pancreas neuroendocrine tumors, Compose looking at aggressive GEP-NETs, Lu-Edotreotide versus best standard of care, and then Raise Bio looking at grade 1 and grade 2 GEP-NETs after Lutathera. So looking to open that one soon.